Good evening, everyone. Welcome to tonight's Lung Cancer Living Room. Thank you all for coming. For those of you who don't know me, I am Danielle Hicks. I am, number one, Bonnie's daughter, the oldest daughter. And the other one may introduce herself a little bit later. But my role here at the Foundation is to oversee patient services and program education. So everything that has to do with the patient touch and information and working with these wonderful docs that we bring to you here is my area of responsibility. So welcome, welcome, welcome. Tonight, as you guys know, and you have seen in whether it was through social media or direct mail from us, Dr. Heather Wakely from Stanford is here. A lot of you in the room I know her. I know some of you in the room are her patients. So I don't have to go too deep into how amazing not only human being she is, but a lung cancer physician. She really does a great job, and she is loved by many. And with that, I'm going to turn it over to Dr. Wakely to give us a little bit of information about who she is and why lung cancer matters.
Okay, great. Well, first of all, I wanted to thank you for inviting me to be here. It's always a really wonderful experience to get to talk to so many people at once. I mean, I give a lot of lectures, so that part's not that unique, but the audience isn't always patients and patient advocates. A lot of times it's other physicians. And I want to emphasize, too, it's not just the physicians. There's a whole care team involved in everybody's treatment. So it's the nurses and the nurse practitioners and the pharmacists and the social workers and advocates for a lot of people. And it's really important to emphasize that team. And I like being part of this team, too, and love my opportunities to work with the Adario Foundation. And all of you have come here to be a part of this, but I want to just emphasize how amazing it is what you guys have built over the years. I think we got to know each other pretty early in the days of the foundation. And to step back and think about how many people have been helped, have been touched by this, by knowing that it's very overwhelming. You come with a diagnosis and you meet the healthcare team and you know that they're there as advocates and trying to help you and do what's right for the individual patient. But it's also very helpful to hear that from someone who's not your patient, or not the patient, not your care team, but someone else who's living through the disease or knows a lot of people who have lived through the disease, and to really help to understand it. I think sometimes people are afraid to ask their care team a question they might think is obvious, but it's to be able to ask it to someone else who's going through it, or to know that there's a place to come for support. I think that's just so critical, and I can't tell you how many of my own patients I know have come and been really supported here. And then also to emphasize the research aspect of it. Everything that we know to do today, we know to do because other patients who've come before have been willing to be a part of trials and to try out those new treatments, some of which have worked and led to things that you all are talking about now, and some of which didn't. I mean, not everything works, and we don't know that without moving ahead and doing those trials and those studies, and to be able to have ways of doing that research from the ground up in the lab to studies to actually being able to try those things in people. And it's not just the treatments, but it's the understanding the diagnoses, being able to know what's the right treatment because I've done this test and therefore I know this is the right thing for an individual. And so the support that's being done for that is really critical. So I want to emphasize that too. Okay. So then me, I haven't treated everyone here. Wouldn't be able to, right? But I've been involved in treating lung cancer patients in this community for quite some time. So I'm a native Californian, a little further north. I was on the East Coast to do my medical training, but then I came back to Stanford to start with, and for those of you who don't know, when you finish medical school, you do a residency, and then you go on to specialty training. And so I came out here to do my internal medicine training, knowing that I wanted to be an oncologist. And so my first day at Stanford, I was on the oncology ward. I showed up an hour late because they gave me the wrong time, but we got over that. And from that time, that oncology ward at Stanford has been a second home to me. Can't tell me how many birthdays I've spent there and other things, but it's been a really important part. It's good. All right, so that's enough about me. So let's talk about today's topic, which is advances in molecular-based therapy. And I go, well, what's molecular-based therapy? Well, I think we're going to back up a little bit as to what is cancer. Right? What is cancer? So cancer, it's when a cell, normal cell, changes in some way. It gets a mutation, or maybe a lot of mutations, that allows it to grow in an abnormal way. Right? That's what a cancer is. And that happens to all of us all the time, actually. We have an abnormal cell that starts to grow in the wrong way. Usually, our immune system comes in and takes care of it, and we don't end up developing a cancer. But sometimes that doesn't happen. And that single cell then divides and makes more cells, and then they make more cells, and then you've got the tumor itself. And then pretty early on, some of the cells start to break off and get into the bloodstream. And if they change again in a way where it allows them to grow in other parts of the body, then that becomes metastatic. So it can go to the brain, if we've heard from some of the people here today, or the liver, the bone, I mean, anywhere. And when does that happen can vary quite a bit. So some people get a cancer, and even when it's barely visible, one of those cells has already figured out how to grow in the brain, and then it's metastatic. And some people end up with a tumor that's gigantic, and those cells never figure out how to grow anywhere else, and you can just take care of it. So one of the things I try to emphasize is not to focus too much on the size, because the size isn't so critical as much as what is it about that tumor that gives it that advantage? Why is that tumor different than someone else's tumor? Why is that tumor able to grow in different places in a way where it's life-threatening? So that's what we kind of think through. And the reason I'm going into a lot of discussion around that is that it's the differences in each individual cancer that allows us to treat people differently, right? That's that personalized treatment. That's a kind of a buzzword we've all heard a little bit, but it's really at the root of that molecular-based treatment. And so when I talk about molecular-based treatment, or when someone does, what we mean is for that particular tumor, we've figured out the gene mutation, and we have a specific way to treat it. Okay, does that make sense to people, right? So in order for a normal cell to become a cancer, there has to be a mutation or many. And what happened about 15 years ago, it was we started to understand, well, what genes are most commonly changed in lung cancer, and we realized that for some of those gene mutations, we can actually treat them, like if they're in specific things. And so I'm going to tell the EGFR story, because that's kind of the beginning of it for lung cancer. And so before we understood that, well, we always knew that in order for a cancer to grow, there had to be mutations, but we didn't understand that, like, well, we could get smart about it until about 15 years ago. So what started off with this EGFR story was scientists realized that if you looked at the cancer, lung cancer, a lot of times there was a protein, the EGFR protein, that levels were really high. And so people said, well, if the protein levels of EGFR are really high in lung cancer cells, and that's different than normal tissue, then maybe we should do something to attack EGFR. And so they went and developed pill drugs that could specifically target EGFR, not the protein, but the DNA part of it. And when they did that and gave it to patients early on, about 10% of people had really dramatic responses, where the tumor like melted away within a very short period of time. And those of you who have EGFR mutant lung cancer, you probably remember when you started treatment, for most people you can feel it's actually starting to work pretty quickly initially. But it wasn't happening for everybody, and so that led the scientists to do more work to figure out, well, why is it working for this 10% and not the rest of them? And that's when realized that, well, in the tumors where there was a really good response for those people, in the tumor itself, there was an EGFR gene mutation, right? So the thing that actually had led to the cancer was that EGFR mutation. And when the EGFR mutation happened, the EGFR protein gets turned on all the time. Normally it's regulated, so it's on, off all the time. But when it's turned on all the time, it led that cell to have a growth advantage, where it didn't die the way it was supposed to. It just kept going on and on and on and on and on. And so when you then turned off that one particular gene, all of a sudden the cancer didn't have its main growth factor, and it kind of died. Didn't completely, but at least it slowed down, was able to shrink. And so this was like the first way, the first kind of key to understanding this molecular-based treatment in lung cancer. We knew about this for a few other cancers before, but no one had figured that out for lung cancer. And so they went back and they realized that in all of the tumors where there was, in all the people who had really good responses, if they looked at their tumor and did these mutation testing to see, well, could they find that, they would find these EGFR mutations in almost everybody. And in the people who didn't respond, they didn't have those EGFR mutations. And so it seems obvious now because we know to test, and many of you have been tested and know, but that was like really interesting in news, and it took a while for us to understand how critical that was. And so that started our kind of paradigm shift where we started testing. And if someone was found to have an EGFR mutation when they were first diagnosed with metastatic disease, we knew to start them on an EGFR pill. And that's why so many of you are on erlotinib, which is also called Tarceva. And some of you are on osimertinib, which is also called Tagrisso, right? That we know that if you have an EGFR mutation and you get an EGFR drug, it works better than chemo if you're just getting started on therapy. And so that was a whole new way to think. But we also then stepped back and said, okay, well, that's amazing and wonderful for the people where we can find this EGFR mutation, but it's only about 10% of anybody who gets lung cancer. And obviously it's a higher percentage here, but it's about 10%. What about everybody else? What about the other 90% of people? And so then we started realizing we could look for these specific gene mutations. And then a little bit later, a few years later, we found the ALK gene mutation. So some of you have probably heard about ALK. And then there was one called ROS1, and then there's BRAF, and now there's MET exon 14, and I mean, I could keep going. But basically, what we know to do now is when someone's newly diagnosed with metastatic lung cancer is we have to look at the genetic profile of the tumor. And these are not things that are in the rest of a person. They're not things that are passed down to the kids. This is something that is just unique to the tumor. It's what makes the tumor different than the rest of the body, is that specific gene mutation. Does that make sense? Right? And so that's really the basis of what is molecular-based therapy. It's understanding what is the gene change in the tumor that makes it the tumor, and can we then do something about it? And so some of the things, yes, we can. The ones I mentioned, if we find an EGFR mutation, we have many drugs now that work for EGFR. And if you find ALK, we've got many drugs that work for ALK. And if you've got ROS1, we've got a couple. And in BRAF, we've got some combinations. And MET, there's a couple. And again, you know, the list kind of goes on. And so that's a really, really important thing to know if you have lung cancer is, well, what are the genes in my tumor?
And correct me if I'm wrong, but it's my understanding that if you have a driver mutation like EGFR, ALK, ROS1, you should exhaust all targeted therapies first before trying immunotherapy. And then with immunotherapy, PD-L1 is a marker. Tumor mutation burden is probably even, from what I heard or understand, it's even a better one. But what you're thinking, because now the combinations of immunotherapy and chemotherapy are being fast-tracked for first-line treatment, and it's my understanding the way it works is that the chemotherapy irritates the cancer tumor so that the immunotherapy can see it easier, even without the PD-L1 expression. And I'm just wondering what your thoughts on that are.
It really is very individual as to what's going to be the right treatment for an individual. There are some truths, right? And one is that if you identify before starting treatment for someone with metastatic disease that they have an EGFR mutation or an ALK translocation, that they're going to do better with a targeted treatment than they are with chemo on average, right? There are always exceptions to that. And that, at least in the setting of EGFR, after first progression, for most people, going to the next EGFR drug is the right thing to do, but not for everybody, okay? And so it's not always about exhausting it. And it's much more complex when we get to the more rare mutations, such as ROS1 or MET. And it's not, in all cases, necessarily that the targeted drug is going to be better than starting with the chemo at that point, okay? So I don't want to make it too simple because these are important questions for people to come back and ask their oncologists. But I don't want people to leave here thinking, oh, well, they're doing it wrong in my case, because it might not be, right? There are going to be subtle differences. The immune therapy question is a good one, and I was going to get to that, but I'll address it now because it's so critical. We talked about the fact that as a tumor has more mutations, it makes it more different than normal tissue, and therefore the immune drugs can better recognize it. And a way of kind of measuring that is the tumor mutation burden. It's the total number of mutations in a tumor. But the immune drugs that we have today, the drugs like pembrolizumab, also called Keytruda, and nivolumab, also called Opdivo, and atezolizumab, also called Tecentriq, and durvalumab, which is also called Imfinzi. Everything has multiple names. those drugs all target something called PD-1 or PD-L1, which is a protein that's on cancer cells and also normal cells. And the way that they work, when we're talking about immune therapy, well, they basically block that drug, the protein interaction between PD-1 and PD-L1. And when that is interrupted, the immune cells, it takes away one of the stop signals. So immune cells are constantly having to go back and forth between a pro and a con signal, right? So that we don't end up having our immune system attack us. It has to be very focused, so there's a very tight regulation. And the PD-1, PD-L1 is one of those stop signals. And if you take it away, then the immune cell is better able to come in and recognize a tumor, right? And especially if that tumor is using that PD-L1 to mask itself and look normal. So what we know from trials for patients with EGFR and ALK is that the likelihood of having a response to an immune drug is much lower than if you have one of those more complex tumors, right? So going back to something we talked about before. And so we know that even though the immune drugs, there's lots of news about them and press, everyone's really excited about them, we know that they're not the best thing early on for most patients with EGFR, ALK, or some of the other driver mutations. I do want to branch a little bit into earlier stages of cancer because we haven't talked about that yet. It kind of started to hint at it a little bit. Most of what I've talked about is for people who have metastatic cancer. But there are a lot of people who are found with the cancer at earlier stages of disease, stage 1, stage 2, stage 3, and I'm not going to quiz you on all the staging, but stage 1 basically means it's just the tumor. It hasn't figured out how to grow anywhere else. And stage 2 means it's the tumor, but it figured out how to grow in lymph nodes in the lung. And then stage 3 is it figured out how to grow in lymph nodes that are in the center of the chest. And then stage 4 means it figured out how to grow anywhere else. So stage 4, obviously, there's a lot of variability in what that means, okay? But it just means it figured out how to grow somewhere else. And the treatments for stage 1 and 2, for most people, we try to remove it with surgery. And some people get focused radiation, and that can be great. And then we will try to improve cure rates by adding other treatments after, whether that's radiation, rarely, or chemotherapy a lot of the time. And what we're trying to figure out is, well, should we add these targeted drugs if someone has an EGFR mutation or ALK that's found early and we can remove it, and now what do we do? And there's a lot of research there. We don't know yet what's the answer. And we're also trying to figure out, well, should we give immune therapy and the chemo or after the chemo? And that's also research that's being done, and we don't know. And then with stage 3, it's really very, very complicated because sometimes it's surgery and sometimes it's not, and sometimes it's radiation and sometimes it's not, and most of the time it's chemo and sometimes it's not. And maybe we should do immune therapy and maybe we should do targeted treatment, but we still don't know. And that's where there's a lot of clinical trial work so we can help know for the future what's the best thing to help cure people, right? And then there's what we know about metastatic disease and what we know about early stage, and sort of how do we bring them together, because it's not always, you can't always take the knowledge from here and bring it into here.
So I want to just, I have a comment.
Okay.
When we're talking a little bit about the genomic profiling, and I think, although I believe in, obviously we believe in patients being educated and informed, there's a challenge with some of the commercial diagnostic companies out there in the way that they are communicating this back to the patient. Well, I know it's generating confusion in a lot of rural sort of community oncology settings, let alone when you're handing a report that's this thick to a patient who doesn't know what they're looking at. And so it's one of the reasons although we encourage this testing be done, and of course for everyone, we also highly, highly, highly encourage that conversation happens with your physician as soon as you can make it happen, or somebody on your care team,
right?
Because it's insanely confusing.
Well, and it is confusing because now a lot of the reports come back and these are the genes that are mutated, but then they take it a step further. And they say, oh, and these are all the treatments that you should be thinking about, and often goes way off into tangents. So I'm like, why are they recommending that? And I can say that as someone who, my job is to really know what's going on the cutting edge with the research and what all has been reported. But If I was in the community in practice and I was treating 10 other diseases, I'm just like, oh, okay, they said to do this, maybe I'll do that, right? So if you're in that setting and you're not really sure, you get a sense from that your oncologist doesn't quite know how to interpret that, not because they're not super smart, but because it's just changing so much all the time.
Yeah.
It's okay to say, hey, you could, do you want to have me get another opinion, or do you want to just call up your colleague? I mean, again, part of my job is to educate not just my patients and help them, but to help people in the community who don't get to focus just in one disease. And we take calls like that all the time.
I think one of the things that's kind of standing out to me tonight, and it does most living room nights, and particularly with a lot of new folks in the room, hopefully a ton of new folks online, is the importance of being with a physician who specializes in this disease, because it is so very complex. Each individual subset is insanely complex, and this is, when you in the community setting, and where Leah spoke a little bit earlier about our community Centers of Excellence program, most patients diagnosed, 80% of them don't have the benefit of a Dr. Wakely, right? Which is one of the reasons we bring this to you, and we're like, you've got her for 2 hours, ask your questions, right? They don't have the benefit of it, and those I feel, even for those physicians, because it's seemingly insurmountable ask of them to know everything there is to know about every cancer that walks in the door, right? Solid tumor and blood cancers. They have to treat what walks in the door. So,
and yet there are still some basic principles, right?
Sure.
And so I think for most people, most of the time, right, as long as some testing's being done and you know the key gene mutations, and a lot of people aren't going to have those. We still have the chemotherapy. We still have now a chemotherapy and immune therapy, and all of this understanding is so critical for helping everybody. But it's still right now, not all folks are necessarily having to get a biopsy every time or having to be with a super specialist, right? I mean, and so I do want to make sure that people who don't necessarily have access don't feel that they're denied. It's good to have this way to kind of disseminate that information and for people to learn and have ways to ask questions.
Exactly.
And a lot of times just to get reassurance. I mean, a lot of the people that come to me for second opinions can say, you're on the right path.
Yeah.
They're doing the right thing.
Yeah.